I imagine there are new treatments becoming available all the time. Are there clinical trials for children with epilepsy?
So look, this is a really exciting time going forward, and obviously clinical trials may help children in the future, but the world has changed a lot in the last 5 years when it comes to the work that's been done to develop medicine specifically for children. When I first started as an epileptologist, we were using medicines that had only had clinical trials in adults, and it wasn't mandatory for pharmaceutical companies to really look at whether these medicines were working the same and were as safe in children. So we had really worked down from medicines tried and proven in adults, then progressively using them in younger and younger children. But in recent years, the large drug regulation agencies have actually said that for drugs to be used in children, they have to have appropriate clinical trials. And that is a really important thing because we really need to know when we're using these medicines, are they working as well as we expect them? How well are they working? It's nice to be able to say to parents, 50% of patients like your child who have tried this medicine have had a significant reduction in seizures, and we know that from trials. So it's really important for us to have that information when we're explaining whether there's a likely benefit from a particular medicine, but also it's really important for parents to know when a drug has been in a clinical trial. Around the world, there will have been at least 150 children who have used that medicine, and they will have been followed for side effect risks. And it's important for parents to know the number of children that have tried this medicine before and that it was safe. So it's a new world at the moment because, in fact, we have a significant number of clinical trials now in Australia that are specifically looking at new medicines in children and new medicines in difficult epilepsies like Dravet syndrome and Lennox-Gastaut syndrome, new medicines in what we call the DEEs, which is a big medical word for children that have significant early epilepsy that's affecting their development. So DEE stands for developmental and epileptic encephalopathy. That's our terrible big medical word for when you have early life difficult epilepsy and it's affecting your development. And there are new medicines that people are bringing to trial. Coming to trial, medicines already have had a whole bunch of checks and balances before they go to, they have to before they go to trial. But these trials are likely to bring us new and more effective medicines that may be very specific for children's brains in the near and in the distant future. So I think that's an exciting time, and I think it's important for families to think a little bit more and learn a little bit more about what a clinical trial is and how that runs, and to talk to your doctors about, ask your doctors, are there clinical trials that might be, my child might be suitable for.
So for those very difficult epilepsies, it gives hope that there's always something new.
Absolutely, and there are definitely important medicines coming through.
When we talk to our clients about the questions they might have for you, there were a lot of comments and questions about sleep and epilepsy and various other things. But if your child has seizures through the night, will that affect their daytime concentration and learning?
So it's not an easy question to answer because we have lots of different causes of seizures in sleep at night. For example, the cause could be a big epilepsy problem, a syndrome that we call Lennox-Gastaut syndrome, and we know that people with Lennox-Gastaut syndrome have, by virtue of that condition, frequent little tonic seizures through the night. But independently, that whole brain problem will affect your concentration and learning, so it's not necessarily the seizures at night. We've got other children that have what we call a frontal lobe epilepsy, which they have frequent seizures at night, but really function normally without any problems with attention and concentration. So it's not an easy answer to draw a line between the seizures and daytime function. People often think, well, if sleep's not great, our daytime function won't be great either. but it's probably, it may be more a little related to the underlying cause of the seizures that are happening at night.
Because back to that underlying cause, isn't it?
Some children will have lots of frequent little frontal lobe seizures that are individually brief, and they function very well. In fact, their seizures are not always identified as seizures because they look a little bit like, a night terror or a sort of sleep-related, people think they're just sleep talking or those sorts of things, and because they function so well at school and they're usually very normal in their academic progress, even in high school, people don't often recognize that they're having seizures for a while.
What about back to medication? Can medication actually affect sleep?
Some medications can. Most medicines don't. Some medications make you more sleepy. Some medications may impact on the depth and quality of your sleep. So there's probably a couple of medicines, I can think of 2 that I know of, that sometimes affect the quality of sleep that you have, how deep you get into that kind of deep, slow wave sleep. And other medicines have no effect on sleep at all. So again, it's probably a question to ask your doctor about your particular medication as to whether this is or isn't going to impact on sleep. Some of the medicines that we use do help you get to sleep, and some parents often are looking for something that manages the seizures and helps the sleep, because sleep can be a little disruptive. Sleep's an interesting thing. It's like walking, talking. It is a function of your brain. It's a brain habit. Your brain kind of has to kick off a process to get you to sleep. And so, when you have something different in terms of how your brain is working, that brain may not kick off that sleep sort of, process very easily. So it can be, again, a little bit like how your brain can be affected with development. Sleep, mood and behaviour are all a function of your brain.
Kate, a very specific question that was asked here, and I'll just read it to you as the person has asked. My son used to be a confident, positive child before his epilepsy diagnosis, and I believe that was frontal lobe epilepsy. He now has a lot of issues at school, including poor attention and concentration, slow processing leading to frustration, word-finding difficulties, feeling self-conscious about seizures, and that's affecting his self-esteem and social confidence. And this person's asking, how can we work with this? And I'd have to say, from Epilepsy Action's point of view, we have a lot of parents that talk to us about those sorts of concerns. What advice would you have for families in that situation?
Yeah, so this is a really, really good question, because there's a lot to unpack, I think, really. First of all, there can be a really big hit for a person with a diagnosis of epilepsy. It depends on the family, the person, how much they will roll with it, and it depends on the child as well. It depends on the seizures. Some seizures can be quite confronting to have in school in front of your peers. And then, of course, there's a phase of protection and restriction, and sometimes schools, often with the best intention, when a diagnosis of epilepsy happens, may put some kind of extra watch on a child. So, sometimes we really have to unpack what's driving what. And there's a set of things here. In the setting of, I guess, adversity, apart from the epilepsy and the underlying cause of the epilepsy and the medications, there's a separate thing that can happen to your brain that we call functional neurological symptom disorder. There's an excellent website on this. It's called neurosymptoms.org. But when our brains are under a degree of adversity and stress or a big life change, a lot of the automatic functions of our brain, the things that our brain does automatically in the background, can sometimes start to glitch a little. And some of the symptoms that this is reported for this child, things like slow processing speed, difficulty with concentration, there's a set of symptoms that are described there that actually fall a little under the what we call FND, functional neurological symptom disorder. And actually, this is a really important topic, because we can get that condition as an overlay on top of everything else, and it's important for this is a condition now that's really well understood. It's a way in which your brain can sometimes struggle broadly in the setting of a lot of complex information, overwhelm, overload, or just lots of things happening in life. And there's that website, neurosymptoms.org, does a great job of explaining it. A lot of the symptoms there's a symptom checklist, and you can hop on there and have a look. And often once families and children understand that this is what's happening in their body, this is why they've got all these extra symptoms, actually there's some simple strategies that help calm that process, that allows your automatic brain networks to kick back in and work better. And we see improvement in attention concentration, that slow processing speed, memory difficulties. It's sort of a little fugue that the brain can go into, and understanding it, reducing what we call health hypervigilance. So, if we're very hypervigilant for medical symptoms, our brain really starts to kind of put a lot of energy into that and doesn't do its other stuff very well, like memory and concentration. So there's a process around bringing down health hypervigilance, understanding those symptoms, putting in some calming strategies when they're there, that actually can treat that side of things very well. And for a lot of our adolescents, we do see both. We see our epilepsy and our epileptic seizures, and we have to manage that side of things. But we also, the rate in which we're seeing that kind of that second condition, functional neurological symptom disorder, is high, and managing that itself really can improve, I guess, everybody's well-being. A lot of those symptoms are treatable. It's not the epilepsy, and once you treat that, you're back to where you were before, and it can make quality of life really much better.
So where would a parent go for getting some help and assistance in that regard?
The first place is neurosymptoms.org. It's a great website. It's fabulous. It explains what's happening. It goes through the symptoms that can happen, and it goes through strategy. General pediatricians and neurologists all help with just confirming that these symptoms are what we call FND, on top of your epilepsy. And then the strategies can often be self-evident to parents and families. It's a real condition where understanding your body and thinking about your own strategies that you can implement yourself to just get your brain back into tune again work very well. It's a condition that the more you go to lots of medical people and consider that you have to therapy out of this, the more you're outsourcing, the more it's not a self-management strategy, the harder it is to get those symptoms under control. So it's a little bit of an interesting one because in the medical world we're all sort of very much geared to what's the problem, who do I need to go to fix it, what therapy do I need, what tests do I need, and in fact this is a disorder. Of course, a lot of that approach increases the health hypervigilance, increases the symptoms, and so in fact it's a slightly different approach. It's understanding the condition. There's often some self-management strategies. I explain those a lot to families, and then that reduces the health hypervigilance. People auto self-correct because that's the best way that our automatic brain, it's designed to auto-correct to its environment, and that auto-correction, those symptoms settle. Of course, some of those children may actually have genuine anxiety, and anxiety itself may need support from a psychologist or a school counsellor to just work through the anxiety. Some children in school, it's very interesting to do a little fact finding because I have had some children really with people with the best intentions of in the world have maybe in protecting a child have maybe kept them close to a teacher. Maybe they haven't been allowed out on the oval where they've always gone out with their friends to play ball on the break. Maybe because there's a midazolam instruction, they have to be within 5 minutes of a particular room in the school. It's really interesting to fact find what the kind of impact on the child themselves, what's changed for them and what do they want to change to make their lives better. We're often not asking the child those sorts of questions, and when you ask them, the answers sometimes come out as to what's really actually changed for them. And so some of those things you have to really do a little bit of fact-finding as well.
Another of our clients has asked a question about her daughter, 14 years old with focal epilepsy. She's been seizure-free for 3 years and had a few really tough years, and the doctor is suggesting we try weaning her off medication. Parents are terrified. They're worried the seizures will return. What's your comment on that?
Just remind me, what age is she, Carol?
14 with focal epilepsy.
Yeah. So I guess I can only answer very broadly, but in general, one would check what the underlying cause is. It could be that there is a little structural difference in one part of the brain. It could be that the epilepsy is actually, there are types of focal epilepsies, we call them self-limiting focal epilepsies, where you're absolutely expected with 100% certainty to grow out of your epilepsy. So it really depends a little on what the underlying cause is, so that you could be more or less certain that the chance of remaining seizure-free is good. In general, it is good to test and see, is your epilepsy long-term? There are quite a lot of focal epilepsies in childhood that remit with age. And of course, at the age of 14, you're coming up to the last few years before you become an adult. You're coming up to driving age. And also really knowing, are you going to be securely seizure-free? You've got a window of opportunity there to test that while the child is still under good parental supervision. But the fine-tuning of how high a risk of seizure recurrence you have would be really understanding the underlying cause. For a lot of children at the age of 14 who've been securely seizure-free for a period of time, it's not unreasonable to do a controlled trial of wean, because if you remain seizure-free, then that works forward very well in terms of being able to drive. You'll still need a medical certificate for a couple of years, but the impact on your driving is a little less. Alternatively, if you are going to have breakthrough seizures, at least you've identified it at that point, then you're back on your medicines, and you need to be seizure-free for 12 months before you can apply to drive. And of course, it depends a little on where the child's planning to be after high school. There's a lot of extra factors to consider, but it's not an unreasonable thing to think about for sure. But it depends on a number of factors as to whether you do or don't. I guess another factor for a girl is going to be being on a medication if you are going to be pregnant in the future. That comes into it because some of our medicines are not safe, or at least we prefer not to be on them during pregnancy. And so I guess it is important sometimes to know, are you going to be on an enduring medicine? Because at that point you would maybe factor in a change of medicine, that if you happen to get pregnant, and we never know when that happens, sometimes it's not always a planned event, that you are on a safe medicine. So that's a specific thing that we have to think about with adolescent girls and young women.
It's a challenging period, isn't it, for all adolescents? And
very much so.
Sounds like good conversations with your doctor
Correct.
are required, and gathering a lot of knowledge.
And including the young person at that age themselves, because they actually usually have a pretty strong opinion what they do or don't want to do.
Of course.
And some of my young people really don't want to come off their medicines, but it's our job to give them counselling. What does life look like staying on your medicines? Is this going to be the right medicine if you do get pregnant? How are we going to manage your adult care? And so I think it's really important to have them central to all of the pros and cons of both options. Ultimately, the decision is largely theirs at the age of 14.
Yeah. We've talked quite a lot about learning and development and challenges, be they real or perceived or feared. What can schools do to support children who have epilepsy?
I think I've got two prongs to that discussion. One obviously is really helping to identify children that have additional learning needs and support needs, and I'm working to support those children. And that can be that they may need to just watch carefully for learning challenges and help usually through the guidance officer with cognitive assessments and learning support. It can be, I think the harder thing that is often missed is the child who may have attentional difficulties, so ADD, and that's often something that's not picked up very well, because kids by the stage where it's just ADD are often in high school and are struggling to just pay attention in a more complex class environment. So recognising those children, and schools can do initial screens for ADHD or ADD when it's just the attention component, and then referring and recommending referral for those children. So those children may just present with, talking a lot in class, not doing their schoolwork, cognitive fatigue at the end of the school day, struggling with their reading because their attention's drifting off so frequently. So that's kind of, those are a group of children that are often not picked up necessarily very well in school. And I guess the other side of the coin is that if a child really has not got a problem with their learning and thinking, the other problem that sometimes can arise and how schools can support those children is actually really recognising their full capacity. So sometimes we spend a lot of time looking at where can we get more funding, and expecting this child may have problems, or putting in some more restrictions, or having a teacher making sure that child's within a 5-minute arm's reach of them if they're to have a seizure. But in fact, for some children, we really need to advocate for the opposite, because we do know that children that don't have problems with their thinking and learning and have very simple epilepsies, we do know that their final we call it psychosocial, their final kind of psychological and social outcomes are not where we expect them to be. Their level of success through university and careers are not where we expect them to be. Social relationships, marriage, adult mental health problems, they're not where we expect them to be. And we think that a lot of that is because of lesser expectations of them, their self-esteem, their self-confidence with their learning. They don't feel the same as their peers because they simply have epilepsy as a diagnosis, even when they're very well controlled and there's no impact on their thinking and learning. It psychologically holds you back. And so I think for some children, and parents as well, and teachers, it's actually really important to be an absolute positive advocate for your child. Yes, my child has epilepsy, but she's entirely able to do absolutely everything. There's no, it's really about, getting out there. Yes, she can be the school captain. Yes, she can go to university. It's really about, because we spend a lot of time dialoguing about what can we do to put in supports, anticipating negativity, but when there's a positive path forward, it's really about articulating that.
That sounds like there's a lot of work for us all still to do, isn't it, being positive advocates?
Yes, absolutely. And I think we tend to do the opposite, and we don't do enough of that. And there's really good long-term research on the outcomes of kids with very straightforward epilepsy that tell us we have to do that. That's our biggest job as advocates, parent and professionals, because there are lots of children that actually have full capacity to be amazing, and when they have, we need to be big advocates for that outcome for them too.
Kate, when should a child have a seizure management plan that's held at the school and implemented as needed? Can you talk a little bit about that?
Yeah, so first of all, when we have epilepsy, so you can have a single seizure. That doesn't mean that you are at risk of recurring seizures. And when we use that word epilepsy, it means that we have a risk of recurring seizures that's reasonably high. So not all children who've had a singular event or are at low risk of having a further seizure need a plan at school, because schools can naturally deal with any child who might have an unexpected seizure. Most schools should be able to, because the risk of a child having a seizure in school is there for all children that are at school. So I think having a dedicated plan that says that your child has epilepsy and tells teachers what to do is required. It's a really good thing to have when your child has a diagnosis of epilepsy. That plan should specify with some degree of detail, but in layman's terms, what your child's seizure looks like. Some children will have other things that are not seizures, and we don't want people treating things as seizures that are not seizures. So sometimes if your child has other types of attacks, it's important that the school know what is and what isn't their seizure. And look, most seizures stop by themselves, usually under 5 minutes. And so most children just need to be managed. We call it seizure first aid. You know, if it's a seizure where they are out unconscious, then there's a position that we call the recovery position. And other children just need to be kept generally safe and then reorientated after their seizure is over. In terms of what is an emergency seizure, a seizure that you would probably need emergency services, what we consider an emergency seizure is if a seizure is not stopping at the 5-minute mark. And that's because some seizures that go to 5 minutes may not stop by themselves and need medication.
So that timing is critically important.
Yeah.
Once somebody has a seizure.
Yeah, and look, even still, a lot of children may have a 5-minute seizure or a 6-minute seizure and it will stop. But that, you know, science tells us that if the seizure is going past 5 minutes, when we look at most people who are having seizures longer than 5 minutes, there'll be a percentage of them that won't stop without medical help. And so that's when we would say an ambulance should be called. So a seizure that's not stopping at the 5-minute mark is usually when it's an ambulance call. And the ambulance are great. They come and they help just recover a person from a seizure. They bring some medicine if needed. But oftentimes by the time the ambulance gets there, the seizure will have stopped anyway. So it's often a precaution rather than anything. The second parameter for potentially calling an ambulance is if you're having an in and out of seizure. And usually we say if it's at least 3 seizures that may be short, but in an hour, they're keeping going. 3 in an hour is too many to expect things to stop without medical help. So again, that's another reason to call an ambulance. Again, things may stop, but if they don't stop, the ambulance is there. They can give you some medication to stop things and bring you to hospital. It's not necessary for children to regularly have their own emergency medicine available to them. So the emergency medicine that we use in hospital and with the ambulance is called midazolam. And that medicine is appropriate to give to parents if a child regularly has emergency level seizures after they've had treatment with medication. So some children may have seizures when they're unmedicated, and of course as soon as they're on medication they may actually be seizure free. So it's children who are regularly on medication, who have poorly controlled seizures and who have habitual seizures that meet those emergency criteria of at least a seizure continuing after 5 minutes or 3 or more in an hour. Those children, we do give families midazolam to give themselves just to sort of manage the seizure initially, at least by themselves. But those families need to be very well trained in how to give midazolam. It needs to be given safely. And if you have midazolam on your plan, it needs to go everywhere with you. It needs to be kept in out of heat, and it needs to be kept in date. And if your child is at school, teachers need to be taught how to give it. Now, lots of families think that to err on the side of safety, they should have midazolam. But it really is not a good idea to have it unless your child's going to need it. And I guess to kind of give you the story behind that, I look after lots of children in that kind of primary school or even high school age. They have never needed to use midazolam, but when you ask what having that on their plan means for them, it often means that they're quite restricted in the school environment. So some of the young boys I've looked after have told me that because they have midazolam on their plan, even though they've never even needed it or ever had it, they're not allowed away from a teacher on break. They're not allowed out on the oval. They're not allowed, they're very restricted to line of sight with an adult or even having to sit inside in a classroom while their other friends are out on break. So it actually has quite a significant impact on a young person's self-esteem and their friendship groups, and even can cause bullying to be separated out as needing to be kept somewhere else for access to midazolam, because there is a 5-minute rule on it. Usually it's given, has to be given if a seizure is continuing for 5 minutes. So I think sometimes having that on a plan when it's not needed is actually only a problem. And so it's really important to have that on the plan if you are likely to use it, if your child has seizures that can require that level of, if they meet rescue emergency criteria, but not to have it on there otherwise, because it does tend to be a little bit of a millstone. If a child's going on camp there often has to be a whole dialogue around how it's going to be given, where it's going to be stored, and the children are aware of this, so they're aware that for them going on camp is a bit of a do, and they have to get
big thing, isn't it?
Psychologically for a child, it's not nice to know that other kids can go on camp, but there's a whole set of adult meetings that have to happen about whether you can or cannot go on a camp. So I think it's really important to make sure that that's there appropriately.
Okay, thank you. And look, finally, are there any lifestyle changes that a parent might make, or any considerations that might make in terms of assisting their child with epilepsy to reach their best potential?
So I think I alluded to that need to be a really positive advocate for your child's abilities. And I think we spend so much time focusing on being good parents by identifying our child's needs or disabilities. And a lot of therapists will be looking for disabilities to therapy. Even cognitive assessors will look at weaknesses. We all have some degree of things that we don't do well. If I went to an occupational therapist, I'm not sure what they would say about me. We have cognitive weaknesses and strengths, and sometimes I think it's really important to balance. Of course, when a child has some difficulties that can be made meaningfully better by a particular intervention, then that's really important. But sometimes there's a lot of excess intervention that actually doesn't make a meaningful functional gain for the child. So I think that's always an important question to ask with all these, visits to therapists and, assessments. What's going to be the meaningful functional gain? Am I seeing it? Is it working? If not, rethink. But balancing that with actually, I think, and children really need this, every child has an ability, every child has positive skills, and we all need to hear what we're good at. We all know when we have managers how devastating it can be to have negative feedback. When we hear positive things, that really helps us to grow and boosts our self-confidence and makes us want to, strive and thrive. And so I think actually it's a very important thing to balance that, meeting the needs of a child by meaningful strategy that improves their functional outcome, but also doing equal justice to their abilities and their capacity, and really growing them by positively emphasising that.
So let's put that focus back on ability and potential.
That's really important.
Great message. Kate, let's end on that note. I think it's such a positive message. Obviously, there's need for good discussion with doctors and a lot of consideration, and some families are really facing very challenging epilepsies. But for many kids with epilepsy, let's put the positive out there. Thank you so much for your time. We appreciate that so much. That's another session of Ask an Expert with Dr. Kate Riney.